I'm waiting
Okay,
for the
shall
thing,
we
so
start?
I can open a little bit. So good afternoon and good evening, everyone. I'm Professor Tharansak Kanchanabut, Chair of the ISN OSCA. It's a great pleasure to welcome you to today ISN OSCA CPC, and thank you for joining us from across the region. Today's case is titled An Adolescent Girl with Lower Limb Purpura, Arthralgia, and Abdominal Pain, looking beyond the obvious, and the user we are already circulated to you guys. The case will be presented by Dr. Ahmad Saki Ansari, and coordinated by Dr. Lim Chao Yen, a medical officer from the Department of Renal Services, Ministry of Health, Brunei Darussalam. We encourage this to be an interactive session. Please feel free to raise your hand or post question in the chat box. Just let us know your name and where you are joining from. With that, let's get started. Dr. Lim and Dr. Ahmad, are you ready?
Yeah, we're ready. Just checking you can hear me again.
Yeah, very well, very well.
Okay, right.
Time can you.
Good afternoon, respected colleagues and friends from across Southeast Asia. And thank you for the opportunity for Brunei to share a case today. So we have Dr. Zaki, our medical officer in Ripas Hospital, to present a case of an adolescent who first presented with a constellation of symptoms, which at first glance might appear straightforward and something that we commonly encountered in clinical practice. However, as the case evolved, it became clear that there was probably something more complex than what we expected. So this case highlights the several themes across in our daily clinical practice, such as the limitations of pattern recognition alone, and also the need to constantly reassess our working diagnosis, especially if the clinical course does not follow the expected trajectory. And also it highlights several challenges that we face, many of us face in this region, such as the limited pediatrics data in guiding clinical decisions and rare clinical presentations. So without further ado, I'll pass on to Dr. Zaki, but we also welcome insights and perspectives from everyone as we go through the case.
So, good afternoon, everyone. I am Dr. Zaki, and I'm going to present this case of, sorry, it's not moving. Okay, so I'm here to present this 16-year-old young girl who is a student of year 12 with no significant past medical history, and she does not have any significant drug history also, other than some intolerance to ibuprofen, which causes a bit of nausea to her. She presented to medical department with 2 days history of ankle pain plus lower limb rashes. Ankle pain started 2 days prior to her presentation while she was playing netball. It was not associated with any injury or any ankle sprain or any trauma associated with it. And pain was just mild to moderate in intensity, and she was still able to weight bear. It was associated with acute onset of red-colored rash that started from right ankle initially, and then later on spread to involve left ankle, and then ultimately spread to involve anterior aspects of both thighs. It was not associated with any itching or any painful lesions. On further systemic inquiry, she also reported to have cough and abdominal pain. Cough was there for last 1 month, and it was dry, associated with some mild left-sided pleuritic type of chest pain as well, and mild dyspnea on moderate exertion. However, it was not associated with any fever, sore throat, or any flu-like illnesses. By the time she had reached to us, cough had already improved actually. Along with that, she also reported to have abdominal pain 3 weeks back, which was also acute onset, intermittent colicky abdominal pain. It lasted for a week and then settled spontaneously. It was not associated with any vomiting, diarrhea, or any fever or any GI bleeding manifestations. Further systemic inquiry was unremarkable. There were no urinary complaints, no frothing, no hematuria. There was no history of any previous skin or throat infections. There was no weight loss. There was no history of any oral ulcers, alopecia, no CNS manifestations, and gynecologic history was also unremarkable. Past medical and surgical history was also unremarkable, except history of left elbow fracture in 2016 when she fell off from bike, and a left fourth toe fracture in 2022 when she accidentally hit the door. Personal family history was also unremarkable. She is unmarried. She is youngest of 3 siblings and currently a student of year 12, and she denies any history of drug or substance abuse. On examination, she was a young girl with fair complexion, thin, lean, comfortably lying in the bed with pulse of 98 beats per minute, blood pressure of 139/89, and she was afebrile. There was no facial puffiness, no pedal edema, JVP was not raised. There was no significant pallor or any jaundice. However, she had rashes around ankle joint and over front of both thighs. Rashes were erythematous, palpable, purpuric, distributed over both ankles and anterior aspect of thighs in the form of knots. Musculoskeletal examination revealed she had bilateral ankle tenderness over both medial and lateral malleolar regions. And on joint examination, there was no clinical evidence of any joint swelling or any joint effusion, with no associated limitation of range of motion. This is the picture of the rash that was taken with the patient's consent. Systemic examination otherwise was unremarkable, with normal bilateral vesicular breathing, normal heart sounds, and there was no organomegaly clinically. So to summarize, we have an adolescent girl with history of mainly purpuric lower limb rash, ankle joint pain, and history of abdominal pain. Before moving on to investigation, would someone like to discuss differentials, or you want me to proceed with investigations?
I think you should proceed with the investigation because it's already appeared in the protocol and the teaser is all attached in the chat box already. Dr. Saki, please go ahead with the investigation.
Okay, sure. Just move. Okay. So on investigations, full blood count showed mild leukocytosis with white cell count of 14, predominantly neutrophil 73%. Hemoglobin was 9.1 initially. CRP was inflammatory marker was slightly raised with CRP of 4.6, ESR of 72. Creatinine was near normal, 82 micromole per liter. Urine examination showed protein of 1 plus with 3 plus blood, and on microscopy there were 21 to 35 RBCs. Urine protein creatinine ratio was 79.5, and urine for dysmorphic RBCs were present 0 to 3. Otherwise, electrolytes were unremarkable. Coagulation profile was also within normal limits. Virologies were negative for hepatitis B, C, and HIV. Initial immunologies were also negative, including ANA, complement levels, and anti-Smith antibodies. X-ray of ankle joint was also unremarkable. Chest X-ray was also unremarkable with no effusions, no consolidations. On ultrasound of the kidneys, kidney sizes were preserved, but kidneys were a bit of echogenic. We can see left kidney. This is left kidney. This is right kidney, a bit echogenic with the size of 11 centimeter.
Okay, thank you.
This is left kidney, also 11 centimeter size and slightly echogenic. So on investigations, actually, we had subnephrotic proteinuria with microscopic hematuria and near normal renal function, and slightly echogenic normal size kidneys on ultrasound. What should be our assessment at this stage, and what should be the differentials? Would someone like to comment at this?
Yeah, anyone want to challenge yourself by list the problem and make a differential diagnosis? I see so many friends from Philippines, NKTI. Anyone from NKTI want to challenge yourself? No? Okay. Well, anyone from the other country, or probably from Thailand or Malaysia.
Hello, can you hear me?
Yep, very well.
Okay. I'm Dr. Warapat, the first year fellow from nephrology unit, Chulalongkorn University. I would like to approach to this case. First of all, let's summary the pertinent finding and the problem list. This will be the 16 years old adolescent female presenting with acute bilateral symmetrical non-erosive oligoarthritis of both ankles for 2 days with palpable purpura at both ankles too, and also have a history of abdominal pain for 3 weeks. Actually, this case, it would be the pattern recognition of the clinical symptom with the classical triad of the inoxarii purpura. But the abnormal things from history is about the dry cough that presents about 1 month ago with a pruritic chest pain of the left side. With a normal physical examination from the history and the normal chest x-ray, so this would be some kind of symptom that already resolved. I doubt it would be some kind of infection of the respiratory symptom and already resolved. And following with this clinical symptom triad of IgA related disease. About the laboratory, the UPCI to convert to my familiar unit is about 700 milligram per gram creatinine, and creatinine is about 0.93 milligram per deciliter. So this is quite elevated. I think it's quite elevated in the setting of the adolescent female. With a high BP, also hematuria with already presented that she already has the dysmorphic red blood cell and the subnephrotic range proteinuria. I doubt she would have some kind of glomerulonephritis. To conclude this into one disease, I doubt she has already got the inoxarii purpura, which is IgA related vasculitis, and also she might have got the IgA nephropathy. Is there any comment, Dr. Thalungsak?
Oh, thank you, Warapat. Anyone else from the other country want to ask or comment or challenge yourself, whatever? Feel free. I think informal. And anyone from Malaysia, Indonesia, or Philippines? While waiting for people this open idea, so I'm gonna ask you, Dr. Saki. So, do you see any dysmorphic red cell cast, or any glomerular hematuria thing?
Yeah, actually, patient had dysmorphic abscesses were positive, and there was
So
persistent microscopic hematuria as well.
do you see the face contrast or something to look at the morphology of the red cell in the urine? Any chance?
So, no, actually, we did not look into that actually, but it was reported as positive in urine dysmorphic abscesses were positive otherwise.
Okay. Anyone else? Oh, so many people out. How about Malaysia? Oh, Myanmar. I see one person, one attendee from Myanmar. Dr. Min, do you want to express yourself? No? Okay. Oh, if no one, so probably go back to Thailand. Anyone from Thailand again? No?
Yes, sir. Sorry, hello? Am I audible?
Okay, Dr. Min, please go ahead. Yeah, you need to unmute yourself first.
Hello, sir.
Oh,
Am I audible now?
yeah. Now I can hear you well. Go
Yeah.
ahead.
Oh, okay, sir. So, it is actually like the earlier fellow said that this is most probably it is the IgA related disease, and I totally agree with that. And but we have to think other differential diagnosis also, maybe other cause and nephritis in this case. So basically the biopsy will give the definite diagnosis only. So up to now, it is the most fit in with the IgA, associated vasculitis or IgA nephropathy only.
So you agree with the problem list, right? Migratory joint pain, purplic rash, hematuria,
Yeah.
proteinuria, subnephrotic brain, and hypertension, I think.
Yeah.
Because the patient have only 16 years old. And also anemia. And ultrasound have a mild echogenicity, and also history of colicky pain and left pleural chest pain, radic chest pain.
Yeah.
So you discuss a little bit what you think about the IgA vasculitis first, and any differential diagnosis besides IgA vasculitis.
Yeah. Any other thing could be also the infection related vascularity, but the complement level is normal. So this basically this what to say, difficult to say that infection related GN, and also the maybe some other cause of vasculitis. So we had to look for that also.
Thank you. Dr. Lee, Dr. Chao Yen, do you, I think I should not conduct. Dr. Chao Yen, you should, whether you conduct the case, because I don't know the case. I saw one person raise hand, Dr. Chan.
There's someone else who wants to share
Hi.
your thoughts? Okay.
Okay, please. Dr. Chan, go ahead.
I'm Chan from Malaysia. I just want to ask, what is the ethnicity of these patients? The ethnicity.
Korean actually.
Korean Malay.
Korean Malay actually, you can say.
Koreans, Malay.
Yeah.
Father is Malay, mother is Korean.
Okay, all right. Just thinking some of the conditions which is more rare, like the familiar Mediterranean fever, can have a fever, joint pains, active urine sentiments, but it's more common to the Middle Easterns, but probably not so in these patients. I think in these patients, top of the list would be still henochildren purpura or IgA vasculitis, in my opinion.
Okay, wonderful. I think this case of back and vein pain and also the GI and chest pain is fades or resolution spontaneously. This is a clue, I think. So anyone want to investigate more? Because we have complement larval in a serology. Anyone need anchor? Or we don't need to think about anchor because of age onset and the patient is only adolescent, not adult. Anyone think about anchor vasculitis or just IgA vasculitis, no differential diagnosis? No. So for the family of Mediterranean fever, Dr. Chan, do you want to investigate anything else?
I think getting the family histories could be important. Regarding the ANCA, I think it's still worth to set ANCA because I think ANCA vasculitis is if I'm not mistaken, it's a bimodal distribution, right? It can be in the elderly as well as the younger age. I think we still can send ANCA vasculitis, ANCA, especially the PR3 and MPO as part of the investigation as well.
Okay, good. Dr. Saki, go ahead.
Okay, thank you. So, so before moving on, I would just like to mention briefly, as a couple of my fellows have mentioned that probably most likely diagnosis they were considering was HSP. So I will just briefly go through the diagnostic criteria. There are two criteria mainly used, ACR and ULAR criteria. These are not actually diagnostic criteria. They had been used mainly for research purposes, but they do still help in diagnosis. So according to ACR criteria, there are mainly four criteria that include palpable purpura, age at onset less than 20 years, acute abdominal pain, and biopsy showing granulocytes in the walls of small arterioles and venules. If two or more of these criteria are positive, the sensitivity and specificity approaches near 90% in distinguishing IgA vasculitis from other vasculitis. Similarly, in ULAR criteria, there is one mandatory criteria that is purpura or petechiae with lower limb predominance. And along with that, there are four minimum other criteria minor that include arthritis or arthralgia of acute onset, diffuse abdominal pain with acute onset, histopathology showing leukocytoclastic vasculitis or proliferative GN with IgA deposits, and renal involvement that includes proteinuria or hematuria. So along with one mandatory criteria, if only one of these criteria is positive, again, sensitivity approaches 90% to distinguish IgA vasculitis from other vasculitis. So until now, this patient was under medical and they also considered henochildren purpura and they were treating HSP with supportive measures, including paracetamol and then just topical creams. And she was also improving. Joint pain was getting better. Rash was also getting better. But at this stage, they referred to renal for opinion regarding the subnephrotic proteinuria, borderline creatinine, and microscopic hematuria. So when she came to renal clinic, she was doing quite fine. There were no new symptoms. Rash had also faded away. She was looking clinically quite well with blood pressure of 111/70. There was no pedal edema also. And her urine protein creatinine ratio had improved from 79 to 54, and with just plus minus protein in dipstick. But microscopic hematuria was still there, 21 to 35 RBCs. Even though she was improving symptomatically and proteinuria was also improving, but creatinine uptrended to 140 at this stage, from 82 initially to 140 now. So what should be our plan at this stage? So we planned for admission and arranged renal biopsy, and also planned for some more immunologies for complete workup. She underwent renal biopsy. It went quite uncomplicated, and further immunologists were also sent. And so let me show you the biopsy results. So it was an adequate biopsy. There were a total of 25 glomes, and this is for on lower magnification. We can see glomes, and let me show you on more magnified view. This is more focused on glomes. Would someone like to comment on the biopsy?
Yeah, probably we gonna ask any volunteer fellow to read pathology or pathology findings. Anyone from Malaysia or Thailand or Philippines or any country else?
Hello, I'm a second year fellow from Chulalongkorn Hospital. In this pathology as finding, I think these are three conguli was seen, and the two of them have a extracellular hyperplasia. I think this is compatible with crescentic and has a mesenteric expansion in the mesenteric area and hypercellularity. From this pathology, I think
Dr. Wani, before you read the pathology slide, so what is your differential diagnosis? You agree with the other discussion?
From the previous differential diagnosis, I think the clinical and laboratory investigation is most compatible with IgA nephropathy due to the clinical IgA vasculitis.
IgA vasculitis, right? Okay,
yes.
Good. Then you agree that you perform kidney biopsy, right?
Yes, I think she has a indication for kidney biopsy if we find out that we clear that she didn't have absolute contraindication. I think we should proceed to kidney biopsy in this patient.
Okay, I'll go ahead with reading the slide. And Dr. Saki, next slide, please.
Okay. This is more focused on the same gloom actually.
Dr. Wani, go ahead.
Should I just explain?
Okay. Yeah. I'll say go ahead.
Okay, fine. So let me just explain. Yeah, on this gloom, we can see there are actually two glooms. This slide is focused on two glooms. This is a more focused one. So we can see this is PSA stain, and then we can see that glomerular tuft is just pushed on one side, and rest of the Bowman space is filled in with some cellular material and some fibrous material, and this is obviously a crescent. And this is we can say that it's a fibrocellular crescent. This is also a PS stain, but here I can see that it nearly normal appearing glomerulus with open endocapillary lumina with no significant hypercellularity, and both Bowman space is also intact. This is another glome, and the same glomerular tuft is pushed on one side, and the Bowman space is filled in with cellular and fibrous material. So it's again a fibrocellular crescent. Yeah. This is silver stain. Again, the same, there is a crescent and the glomerular tuft is compressed on one side. Rest of the Bowman space is filled with crescent. This is HNH stain. Let me show you more focused one. This is focused on one glome, and we can see some interstitial inflammation as well, some interstitial infiltrates, and this glome again looks nearly normal. There is no significant hypercellularity, and endocapillary lumina are also not obliterated. And this is focused on two glomes actually, and we can clearly see the difference. This glome, which appears nearly normal, and then this one, which is, let me focus more. So this glome, we can see that we cannot properly appreciate the normal glomerular architecture in this glome. It's all filled in with hyaline material, and we cannot see properly the endocapillary lumina and Bowman space as well. So it's actually a globally sclerosed glome. So the report
because
final was there were
we have
5
so many
glomes. 2 were
another
globally sclerosed, 2 were unremarkable,
Dr. Saki,
and with that there were 15 cellular crescents with fibrinoid necrosis and 5 fibrocellular crescents, and 1 only fibrous crescent. Along with that, mild lymphocytic
Saki, do you hear me?
Mild interstitial fibrosis involving less than 25% of the cortex. There was no tubular atrophy, and vessels also appear unremarkable. And surprisingly, immunofluorescence was all negative, including IgA. To summarize, we had crescents of variable age, mixed cellular and fibrocellular crescents, mild interstitial fibrosis and tubular atrophy, and completely negative IgA. So based on histopathological findings, what should be our diagnosis then?
Dr. Saki, do you hear us?
Yeah. Now. Yeah. Now.
Okay. Because we have so many kidney pathologists in the Zoom, so probably we're gonna allow kidney pathologists raise any point or comments on your pathology slide. Is any kidney pathologist want to say something? I saw many names that is a kidney pathologist. Probably we can learn from them as well. Oh, the Professor Bunyalit and on Nick. Do you want to raise any idea on the slides?
Do let me know if any specific slide you want me to show.
No, maybe.
I mean, I agree with the reading.
Oh,
I don't have much to add.
What you are saying, Chilasit?
I said that I agree with the reading.
Okay, you agree. And why the immunofluorescence is negative? Because we expected for IgA vasculitis.
are
So we expect to see the strong IgA staining, right? Oh, while waiting, Dr. Chan Chi
Yeah,
Eng,
I think based on this HPE, we can sort of conclude that this is a post-immune crescentic GN. Because basically the IA is negative. So I would like to look at the ANCA serology if any ANCA serology sent for the especially the PR3 and also the MPO.
Okay, so you're still thinking about ANCA because of bimodal distribution.
Bimodal, and also the HP is a post-immune crescentic GN.
Okay. Dr. Saki, do you have any ANCA serologies?
Yes, I think, yeah, I'll just move on then. So based on histopathology, obviously it looks like post-immune crescentic GN. So what actually was clinically appearing as HSP, so histopathologically it was appearing as post-immune vasculitis. And meanwhile, MPO ANCA came back positive with titer of more than 200.
Oh, wonderful, Dr. Chan. You are right. Wonderful. Congratulations. So actually, for the ANCA, usually the disease tend to be progressive, persistent damage without spontaneous resolution. So that's why no one beside you that thinking about ANCA vasculitis. Wonderful job. Okay, Dr. Saki, go ahead.
So the diagnosis of MPO ANCA vasculitis was established, and so just few words about ANCA vasculitis. As we all know, ANCA vasculitis is mainly a disease of older adults, and its incidence varies according to the type of ANCA. Prevalence of MPO ANCA cases is 9 to 94 cases per million persons, whereas prevalence of GPA is 2.3 to 146 cases per million persons. Incidence also varies widely depending upon geography. GPA mainly affects regions of the world in which population is predominantly of European ancestry and is rarely observed in East Asia, whereas MPA is more predominantly observed in Asian countries such as China and Japan. According to French and United States studies, incidence is twofold higher in a wide population for both GPA and MPA. Although it has been reported in all age groups, but most commonly occurs in older adults, and it rarely affects children. And in adult studies, males and females are equally affected. As we know, it's a small vessel vasculitis, and small blood vessels in almost any organ or tissue can be involved, and in GPA and MPA both, and therefore it has multi-organ involvement and variable presentations. But the respiratory tracts and the kidneys are the most commonly affected organs. According to NIH studies, 77 to 85% of the patients with renal involvement, they ultimately develop with MPO ANCA and GPA, they ultimately develop GN, and typical presentation is of course of RPGN picture. However, other presentations may also be there, like asymptomatic hematuria, slowly worsening kidney function, or some subnephrotic proteinuria. So if we see a literature review on childhood onset ANCA vasculitis, the data is very scarce. Mostly we can find some case reports and few small studies. I will just briefly go through a couple of them. So this is a retrospective study done in Central California, which included 21 patients with age less than 18 years who were diagnosed with ANCA between 2010 and 2021. They analyzed initial presentations, including demographics, clinical laboratory characteristics, and treatment and initial outcomes. So these are the demographic characteristics of these patients. So there were a total of 21 patients. Out of them, 12 were MPA and 9 were GPA. And median age of diagnosis was 14 years. And we can see that out of these 12, there was female predominance, especially in MPA. Out of 12, 11 were females in MPA, as compared to only 4 out of 9 in GPA. And we can also see some racial differences also. The MPA patients, they were predominantly that is 67% of Hispanic origin in this study. And GPA, they were mainly of white origin, 78% of the cases. And if we look into comparison of clinical presentations, we can see that 90% of the total patients, they had renal involvement. 90% of the total patients, they had renal involvement, predominantly in MPA cohort. And in MPA cohort, we can see 12 out of 12, that is 100% of the patients, they had renal involvement, as compared to 7 out of 9, that is 78% in GPA. And this is comparison in terms of disease severity. And we can see MPA cohort, they had they were more at risk of ICU admissions, and they were more patients were needing dialysis in MPA cohort as compared to the GPA. So we can say that severity of disease was more evident in MPA as compared to GPA. In terms of treatment comparisons, 5 out of 12 patients, they received combination of steroid plus cyclophosphamide, and 5 also received steroid plus rituximab. As compared to GPA, they received 7 out of 9 patients, they received steroid plus cyclophosphamide, and 2 of them received combination of cyclophosphamide plus rituximab. So conclusion was microscopic polyangiitis was the most frequent ANCA-associated vasculitis subtype with female predominance, shorter duration of symptoms at onset, and higher proportion of racial ethnic minority patients. Hispanic children demonstrated frequent MPO positivity and trend towards higher rates of ICU requirement, and need for dialysis upon initial presentation was noted in MPA. So patients with MPA received rituximab more frequently. And future prospective studies are needed to understand differences in presentation and outcome in childhood onset ANCA-associated vasculitis between diverse racial ethnic groups. Similarly, in another study, this is again a multi-center retrospective observational study done on 54 patients with renal biopsy-proven childhood onset ANCA vasculitis. So there were a total of 54 patients were included who underwent renal biopsy and found to have either MPA or GPA. And these cases were taken from 9 nephrology and rheumatology centers who had expertise with ANCA-associated vasculitis management. So out of these 54 patients, again, they were predominantly of female patients, 64%, as we can see, 35 out of 54. And majority were MPA again, 66% of the cases. So clinical phenotype was almost similar as compared to adults, but patients with GPA had more frequency of eye and ENT involvement other than that. And 60% of the patients, they had variable degree of renal dysfunction. 7 were on dialysis at the time of diagnosis, and 21 had isolated urinary abnormalities. Majority of the histopathological class were 50% of them were presenting GN. 85% of them received cyclophosphamide, and 9% they received rituximab. So after a median follow-up of 72 months, 33% of the patients with MPA and 2 patients only, that is 11% with GPA, reached end-stage renal disease. So majority of the MPA patients, that is 33%, they reached end-stage renal disease in this study again. Only 1 patient reached CKD3. All remaining patients, they had an almost complete recovery of the renal function. So again, conclusion is that in largest series of biopsy-proven renal ANCA-associated vasculitis with childhood onset reported so far, we observed a high frequency of end-stage renal disease, that is 25.9% overall, which was more pronounced in MPA. So pediatric ANCA-associated vasculitis therefore remains a severe disease and a challenge for the clinicians. So to summarize the literature review, we can see that childhood onset ANCA vasculitis is predominantly MPA patients with female predominance, and there is more incidence of renal involvement and severity of disease in MPA patients. How to treat?
Wonderful.
So as we know that immunosuppressive treatment is needed in almost all cases with active GN. And initial management approach also depends mainly on severity of the disease. For those with organ or life-threatening disease, of course, we start with steroids in combination with cyclophosphamide or rituximab. I can just go. So in our patient, we started with steroid induction with IV methylprednisolone 3 doses, followed by oral prednisolone 50 milligrams daily. And next question obviously was whether we should choose rituximab or cyclophosphamide as induction agent. So here I would like to ask if someone would like to comment which one we should use for the induction.
So before, okay. Anyone from floor want to discuss about any induction treatment? The chant, because you are the person who give a correct answer.
Yeah, here, if let's say in this young female 16 years old girl, if you have rituximab available, I would prefer Ritux to preserve the fertility. If you are not Ritux is not available or the cost is an issue, then I would think Cyclo could be the sensible alternative options for her. But if you have the Retux, if you can access the Retux, I would say the Retux would be the preferred options. Yeah. What do you think?
For the fellow, I think we all agree that for the ankle vasculitis, we need to treat, no doubt, because if we don't start treatment, right?
Yeah, I think
90% we're gonna die.
Yeah. So I think based on two landmark trials, Retux and RAVE trials, comparing rituximab and so also versus cyclophosphamide, I think the rituximab is not inferior to cyclophosphamide in terms of inductions, but in cases like PR3 tends to have more relapsings, then we would prefer Ritux over cyclophosphamide in those cases. But you need to take other things into consideration as well, like cost, the drug accessibility, as well as the patient profile, whether it's a young female, they would like to preserve the fertility. Yeah, there's the things that you need to take into considerations.
So the current creatinine level, Dr. Saki, is less than 3.4.
Yeah. I'll just show you trend also. It's improving actually.
Okay, good. Any idea from the floor? Want to challenge yourself or want to ask Dr. Saki for the case? Very challenging case. No.
Move on.
So how about the patient have anemia? Do you
actually
work on anemia?
initially on presentation we had anemia with HP of 9.1, but iron stores were also low, so we just replaced some iron and then it improved to 12.
Okay.
So actually it was also like on initial presentation just she had anemia, but it improved.
Oh, thank you, Dr. Chan, for sharing us with AJKD core curriculum for 2020. Thank you. Also KD go 2022 as well, if you have that, for just in case fellow. Wonderful. Thank you so much.
Okay.
Anyone else? Okay. Let's say Saki, go ahead. Nice, so go ahead.
Okay. So before moving on, if we look into KDICO guidelines, they also suggest that those patients with severe renal dysfunction, including rapidly declining kidney function or creatinine more than 4, they suggest is to consider cyclophosphamide or combination of rituximab and cyclophosphamide in this setting. And data to support use of only rituximab in these scenarios is limited. So as per KDICO, if the disease is severe, they prefer cyclophosphamide other than rituximab. This is from KDICO recommendations. But there are many other factors also which we have to keep in mind before making any decision, which include age, fertility, risk of steroid toxicity, type of disease, whether it's relapsing disease, PR3 disease, or access to rituximab, and severity of GN as well. So this table again taken from KDICO guidelines, and we can see that cyclophosphamide is preferred in those cases with severe GN, and where rituximab is not available, obviously, then we have to use this cyclophosphamide. And rituximab is mainly preferred in those with extremes of ages, including children and older frail adults, and those at risk of fertility, and those at risk of steroid toxicity. So considering in our patient, considering her age and fertility and the severity of disease, we decided to give rituximab 1 gram 2 weeks apart. This is the creatinine trend. Over course of her illness. At presentation, it was 82, which increased to 140 at the time of biopsy, and peaked to 153 at the time of induction. And after treatment, it improved down to 103 when she was getting second dose of rituximab, and later on improved to 87 at 6 weeks. However, MPO ANCA titers, they remain persistently elevated, more than 200 during the treatment course. Here, one question arises that is there any correlation of MPO ANCA titers with the disease activity? Would someone like to comment here? The correlation of MPO ANCA titers with disease activity?
Yeah, I think it's 2/3 of the case correlate well with disease activity, but 1/3 doesn't correlate with the disease activity. Yeah, only 2/3.
Okay, fine. So the practice of measuring ANCA titers during follow-up visits, it varies from clinician. Mostly, I mean, mostly ANCA titers, they are not a reliable disease marker of disease activity, but still it's a reasonable approach to closely follow a patient with rising ANCA titers, because they might be at increased risk of relapse in future. But still, we don't usually change treatment until or unless patient actually have clinical signs of disease. This is the best data about the role of ANCA titers comes from meta-analysis of 9 studies that examined association of a rise in ANCA titer during remission with likelihood of relapse. So we can see as a predictor of relapse, rise in ANCA titer had sensitivity of 56%, and persistently positive titers had a sensitivity of 38%. So they concluded that among patients with ANCA-associated vasculitis, rise or persistence of ANCA during remission is only modestly predictive of future disease relapse. And there is limited use to serial ANCA measurement during disease remission to guide treatment decisions for individual patient with ANCA-associated vasculitis. This is the steroid regime that we used, initially 50 milligram, and now patient is down to 20 milligram at 6 weeks. So next question was about maintenance, which maintenance option we should choose. Again, if we look back into the KDICO guidelines, they suggest maintenance therapy with either rituximab or azathioprine with low dose steroids after induction of remission. Again, the decision between rituximab and azathioprine depends on various factors, as are shown: the type of disease, if the disease is more at risk of relapse, and age and risk of steroid toxicity as well. Rituximab is the preferred option in those at risk of relapse who are more at risk of steroid toxicity, and whereas azathioprine is mostly considered in those cases where availability of rituximab is a problem. These are the just regimes. I will just go through them. In the last, I will just go through about novel therapeutic option of avacopan in the treatment of ANCA vasculitis. Avacopan, which is a C5a complement inhibitor, can be used as an adjunctive agent with standard injection therapy to limit
Dr.
use of
Saki,
steroids.
because we have only 3
It
minutes
can be
left.
given as 30 milligram twice daily in combination with shorter reduced dose of steroids, which can be tapered then over 4 to 6 weeks time. Few cautions that we have to exercise while prescribing
Dr.
avacopan
Dr.
are
Saki, we have only 3 minutes left.
who are taking strong CYP3A4 inducers, in which we have to reduce the dose. So this is advocate trial that was done on avacopan. So use of avacopan was supported by this trial. In this, there were total of 331 patients who were newly diagnosed with ANCA or relapsing ANCA vasculitis. They were randomly assigned to either receive oral avacopan 30 milligram twice daily or prednisolone on tapering schedule. All patients received standard induction regimes also other than this avacopan, and approximately 80% of the patients here, they had renal involvement, and all those were included who had GFR of more than 15. GFR less than 15 were excluded in this from this trial. So in results, we can see that at 26 weeks, the rates of disease remission were similar between the two groups, 72% in avacopan group versus 70% in the prednisolone group. And at 52 weeks, sustained remission was higher in avacopan group as compared to those who were taking prednisolone. So serious adverse events were comparable. Just abnormal LFTs was a bit more in avacopan group, as we already know that it can affect the liver functions. Otherwise, overall serious adverse events were comparable. So in conclusion, in this trial involving patients with ANCA-associated vasculitis, avacopan was non-inferior but not superior to
Dr.
prednisolone
Saki,
taper.
you have to wrap up.
And
okay.
Prednisolone taper with respect to sustained remission at weeks 52. All patients received cyclophosphamide or rituximab as well, and safety and clinical effect of avacopan beyond 52 weeks were not addressed in this trial. And this is again post hoc analysis of the same advocate trial, which did not identify a subset of patients with GP or MPA. Among patients with kidney involvement, rate of remission were comparable with avacopan and prednisolone, but overall relapse rates after remission were lower with avacopan as compared to prednisolone taper. Avacopan suggestion has also been incorporated in KDIGO guidelines that avacopan may be used as an alternative to steroids, especially those patients who are at risk of increased risk of steroid toxicity. But unfortunately, we don't have avacopan available in Brunei as of now. In the last, just few words about role of transplant, which significantly improves survival in these patients as compared to those who remain on dialysis on waitlisting of transplant. These patients are good candidates for transplant, and positive ANCA at the time of transplant is not a contraindication, but patients should be in clinical remission for at least 6 months before transplant. In this study, we can which included 468 patients, patients who received a kidney transplant had a 53% lower risk of death than those who remained on dialysis on a median over a median period of 61 months. Similarly, 10-year patient survival was also significantly better, 72% in among those who received transplant as compared to those who remained on dialysis. That's all. Thank you.
Okay. Thank you so much for spending time with us today and very active participation. And again, congratulations for Dr. Chan from Malaysia for excellent clinical listening and giving the correct answer. So before we gonna end, so probably we should switch on your camera so we can take a quick group photo as usual. And during waiting, the session recording will be uploaded to the YouTube shortly, and we will share the link so we can pass it on to the colleagues and trainees.